So welcome. In this virtual lecture, we are going to talk about fetal circulation. Basically, we want to look at how blood flow through the fetus. Before we talk about fetal circulation, perhaps it's important that you understand that the cardiovascular system is the first system to fully function in the embryo or the fetus as well. And we ask ourselves, why should the cardiovascular system be the first system to fully function? So that, as a matter of fact, the first heartbeat is actually felt or experienced in the 4th week after fertilization, within the 4th week. If you translate that to dating according to the LMP, that would be within the 6th week. And it's actually within the 6th week, not after the 6th week, because usually the first heartbeat will be at around day 23. So it's actually the earlier part of the 4th week or the earlier part of the 6th week, if you look at it in terms of LMP. The reason why cardiovascular system need to function much earlier is because as the baby is growing, and very fast for that matter, there's need to transport substances. Diffusion alone cannot be able to sustain this kind of transport of substance because the baby is growing so fast. And so because of that rapid growth, diffusion is not efficient. You need a very efficient way that will help to transport substances, either within the baby, between the baby and the placenta, whatever. So cardiovascular system must develop quite early to be able to sustain the need to transport substances. That is why the heart develops much early, and that is why cardiovascular system is the first system to fully function. There are some unique features of the fetal cardiovascular system. If you compare the fetal cardiovascular system with the cardiovascular system that is there after delivery of the baby, there are some things which are worth noting. Of course, we are aware that the fetal cardiovascular system does not have a functional pulmonary circulation. That is to mean that blood does not go to the lungs for gas exchange. Well, we are aware that the baby doesn't really use the lungs for gas exchange. Instead, gas exchange occurs in the placental circulation. And so the fetal cardiovascular system has a placental circulation where gas exchange must take place. Well, there are other functions of the placental circulation other than just gas exchange. There's something else. In the cardiovascular system of the fetus, oxygenated stream of blood can mix with the deoxygenated stream of blood. Or let me say that usually the oxygenated stream of blood mixes with the deoxygenated stream of blood. And that is considered normal in some vascular beds. We don't quite take that postnatally. The oxygenated stream of blood is fairly separated from the deoxygenated stream of blood. And usually there's no mixing, apart from maybe somewhere in the lungs where the bronchial veins may drain to the pulmonary veins, very slight mixing. Otherwise, for the general circulation, usually the deoxygenated stream of blood does not mix with the oxygenated stream of blood postnatally. In the fetus, it does. So this, we find that unique. Now, to achieve those things that you mentioned, the fetal cardiovascular system is designed in this way. First of all, it is designed to maintain blood towards and away from the placenta. So there's a blood vascular connection between the baby and the placenta. And this vascular connection is via the umbilical vessels. So we have functional umbilical vessels, which ensures that blood goes to the placenta and comes out of the placenta. Remember, there is one umbilical vein from the placenta and two umbilical arteries to the placenta. Even though there's one umbilical vein, that is not the scenario from the beginning. From the beginning, there were two umbilical veins and two umbilical arteries, but one umbilical vein involutes so that there's only one that persists. So the one that persists carry well-oxygenated stream of blood from the placenta to the baby. That is umbilical vein. And then umbilical arteries carry, I don't want to say deoxygenated, but maybe let's just say moderately oxygenated or blood that is low in oxygen from the baby to the placenta. Two umbilical arteries, one umbilical vein, they're all contained within the umbilical cord. And remember, the umbilical cord is surrounded by a particular connective tissue, which we call Wharton's jelly. Apart from that, the fetal cardiovascular system is designed in such a way that it's able to bypass the non-functional pulmonary circulation. To bypass is to shunt. Now that blood does not go to the lungs of the fetus for gas exchange, there's a way blood is rechanneled away from the lungs. And there are two shunts we are going to talk about. One is called the Foramen ovale, and another one called the ductus arteriosus. Those two shunts ensure that blood does not go to the lungs, but is redirected away from the lungs. So they bypass the pulmonary circulation. Even though we are saying that oxygenated and the deoxygenated blood mixes, in the fetal cardiovascular system, it is also designed in such a way that even though those two streams of blood mix, relatively oxygenated stream of blood is still rechanneled to the developing brain. The reason is because the brain requires high levels of oxygen. And so blood is still going to the brain. Oxygenated stream of blood still goes to the brain despite the mixing. And we are going to see how that is achieved. Now, it's not just the brain only. There are 2-3 other organs that also require high levels of oxygen. The liver is one of them. It also receives well-oxygenated stream of blood. The heart is another one. It also receives well-oxygenated stream of blood. The thyroid gland is another one, and it also receives well-oxygenated stream of blood. So those 4 organs, brain, liver, heart, and thyroid gland, require high levels of oxygen in the fetus. Even though oxygenated and deoxygenated streams of blood mix in the fetus, those 4 organs are still able to receive well-oxygenated stream of blood. And we'll see how that is achieved. Last but not least, based on this unique design, one keeps on wondering, So what will happen when the baby is born? There's some radical changes that must take place when the baby is born. And so we keep on wondering, so how will the baby handle those radical changes? The design is also in such a way that's able to actually anticipate and handle those radical changes that are going to take place at birth. We'll be seeing the radical changes, and we'll be seeing how the fetus the neonate handles them. So in terms of what we need to learn, therefore, we first need to describe how blood flows through the fetus, so specifically through the fetal heart. We are also going to name the fetal shunts and state the role of each shunt. We'll outline the changes that occur in the cardiovascular system at birth. And we'll also talk about the structures which are formed by the remnants of the fetal circulation. There's some things that the fetus has in their cardiovascular system that the adult don't necessarily have. What do these structures in the fetus become? Okay, let's look at it this way. Fetal circulation can be a bit complex if you look at it on a nutshell, but if you look at it in detail, it's actually not very complex. The easiest way to describe fetal circulation, or what I find easier, is basically to describe how blood will flow from the placenta and all the way back to the placenta. That will help you understand the fetal circulation. Okay, so let's look at it this way. Let's consider this structure here to be the placenta. We have indicated that the placenta has some vessels connected to it. The vessel that comes from the placenta to the baby is what we call the umbilical vein. This umbilical vein is located within the umbilical cord. And we've mentioned that this umbilical vein carry well-oxygenated stream of blood. Maybe while we're there, I want you to take note of some terms we are going to use in terms of describing the level of oxygenation of fetal blood. And there are some three terms that we need to be clear with here. One of them is that the blood can be well oxygenated. So that's one category. Another category is that the blood can be moderately oxygenated. And the third term is that the blood can be poorly oxygenated. So well oxygenated, moderately oxygenated, and poorly oxygenated stream. Let's have those in our mind. The blood within the umbilical vein is well oxygenated. So it comes from the placenta all the way. Remember where the umbilical cord attaches on the baby, somewhere in the umbilicus. From the umbilicus, that vessel is still inside the baby, and that umbilical vein usually goes to the liver. So let's take that to be the liver of the baby. So don't think that that blood goes anywhere in the heart direct. It actually goes to the liver. When it goes to the liver, something fundamental happens. Yes, the blood goes to the liver, and some vessels leave to supply the liver. What does that mean? The liver has received well-oxygenated stream of blood. So at least we've ticked one box. I told you there are 4 organs that need to receive well-oxygenated stream. We've ticked one of them, the liver. Although that blood goes to the liver and some vessels supply the liver, there's a larger part of it that does not actually deliver its blood to the liver, but goes through the liver. That's unique. What's unique about it? You know, when a vessel goes to an organ, we expect that vessel to divide into arterioles and capillaries, and so supply that organ, and the blood that come out of it should be deoxygenated or low in oxygen. For this umbilical vein, we are saying that yes, it goes to the liver, but there's a large tract that does not deliver its blood to the liver. So that large tract that does not deliver its blood to the liver, although it passes through the liver, is the first fetal shunt we are mentioning. We call that the ductus venosus. So the ductus venosus is a shunt. It's a bypass. It is located within the liver. Which circulation does it bypass? The hepatic circulation. So it bypasses the hepatic circulation, which means that the blood within the ductus venosus does not deliver its oxygen to the liver, but passes through. It has bypassed the hepatic circulation. After it has bypassed the hepatic circulation, it joins with the blood which comes from the lower limbs and maybe the rest of the lower part of the body. The blood is located or contained within the inferior vena cava, as we know. So this is the inferior vena cava. This blood, well-oxygenated stream, joins with the blood from the inferior vena cava, which is poorly oxygenated stream for obvious reasons. We know where it's coming from. So there is mixing, and that's an ouch, there is mixing. Although there is mixing, we are fairly protected in a way that the blood that is contained within the inferior vena cava at this point is not that much. Because remember, much of these functions, maybe for the kidney, is being served by the placenta as well at this point in time. Excretion of substances. And so we can say that the organs in this lower part are very metabolically active. And so the blood is not really so much from this lower part, and not so much in terms of depletion of oxygen. What I'm just trying to tell you is that even though there's dilution here, the blood in the ductus venosus still has an upper hand. And so I'm saying that even though there is mixing, the blood is still having some good oxygenation. That's what I'm saying in many words. This blood here enters the right atrium of the heart. So the blood in the inferior vena cava enters the right atrium. Remember, it's still well oxygenated. It goes to the right atrium. We know that the right atrium receives blood also from the superior vena cava. The blood in the superior vena cava is poorly oxygenated. If it was possible to say very poorly, I would have said it. This is because this blood is actually coming from the upper part of the body, which means it's coming from the brain is one of them, very metabolically active. So this blood is being depleted oxygen significantly, superior vena cava. Now, that's another ouch. We have a stream here that is good in oxygen levels. We have a stream there that is very poor in oxygen levels. They both mix within the right atrium. Interestingly, and this is one of the wonders of embryology or wonders of the creation of God, even though that those two streams meet within the right atrium, they don't really mix significantly. Why do we say so? There are two exits from the right atrium. One through there, we call that foramen ovale, and another through there, we call that the tricuspid valve. These two streams which enter the right atrium will exit using these two exits. One stream will take one exit and the other stream take the other exit, so that there is no significant mixing. That's wonderful. Question is, which stream would take which part? You have to think through the concept of streamline flow for you to understand that. Also, you have to remember your lecture on anatomy of the heart, and especially anatomy of the right atrium. If you remember, there are some 3 valves in the right atrium. The tricuspid valve, taking blood from the right atrium to the right ventricle. The valve of the inferior vena cava, and the valve of the coronary sinus. Now, the valve of the inferior vena cava ensures that when blood comes from the inferior vena cava, that blood is redirected through foramen ovale. If you remember that anatomy of the right atrium, the inferior vena cava is very close to the fossa ovalis, or the embryonic foramen ovale. And so the valve of the inferior vena cava, the Stitian valve, channels the blood from the inferior vena cava through foramen ovale. So that blood from the right atrium, blood from the inferior vena cava goes through the right atrium, then goes through the foramen ovale to the left atrium. Remember, that stream is well oxygenated. Then blood from here, superior vena cava, poorly oxygenated stream, go direct down to the tricuspid valve to the right ventricle. So yes, the two streams mix, but not physiologically significant mixing. So the two streams still have their oxygenation levels as we wanted them to be, or fairly so. I want you to note that the well-oxygenated stream has gone to the left atrium, and the poorly oxygenated stream has gone to the right ventricle. Let's pick one of the streams and follow. In this image, we can see that mixing has occurred there kidogo, slightly. So the one from the inferior vena cava gone there to the left atrium, the one from superior vena cava gone there to the right ventricle. I want us to follow the stream to the left atrium. So from the right ventricle, that stream went through foramen ovale. And so foramen ovale is the second fetal shunt we are mentioning. What does it do? It shunts blood from the right atrium to the left atrium. By doing so, we are now skipping the pulmonary circulation, as I told you earlier. But remember, this stream being skipped here is a stream that is actually good in oxygen levels. So it bypasses well-oxygenated stream of blood from the right atrium to the left atrium, hence bypassing the pulmonary circulation. That blood will then go to the mitral valve, through the mitral valve to the left ventricle. From the left ventricle, we can trace that. It will go to the ascending aorta through the aortic valve. Now I want you to be keen here. The moment it is in the ascending aorta, what does that mean? It means that the heart can also receive that oxygen. So remember, it is well oxygenated stream. We've seen now the heart is the second organ privileged to receive good levels of oxygen through what we've talked about. There was mixing, yes, but the heart is still receiving good levels of oxygen. The heart is supplied by coronary arteries from the ascending aorta. Now let's see. From the ascending aorta, the blood will go to the arc of the aorta. I hope you remember the branches of the aortic arc. The first branch is the brachiocephalic trunk, which gives you the right subclavian artery and the right common carotid artery. The second branch is the left common carotid artery, and the third branch is the left subclavian artery. These four arteries, two subclavian arteries and two common carotid arteries, supply one common organ, the brain. And so we realize, therefore, that the brain is also privileged to receive good levels of oxygen. The subclavian arteries give you what you call vertebral arteries that go to the brain. Common carotid arteries will give you what we call internal carotid arteries, which also go to the brain. And so through this, we can say that the brain is a third organ privileged to receive good levels of oxygen through that route that we talked about. I mentioned to you that thyroid glands are also privileged. Thyroid glands are supplied by, again, these two. The common carotid arteries give you external carotid arteries that will supply the thyroid gland. And so thyroid gland also receives good levels of oxygen. And perhaps you're wondering why I have to insist on thyroid gland. You know, thyroid gland produces thyroid hormones, which help in metabolism. We need high metabolism in the fetus. And so the thyroid gland of the fetus is actually very active for that reason. Right, so four organs have been privileged to receive good levels of oxygen through the mechanisms or the channels we talked about: liver, heart, brain, and thyroid gland. Of course, when blood goes through the aortic arc, that does not mean that it will all go there and nothing goes this way. There's still some blood that goes that way to the descending aorta. Let's put a comma there at the descending aorta and now follow the other channel which came from the superior vena cava. The channel that comes from the superior vena cava is poorly oxygenated, enters the right atrium, then go through the tricuspid valve to go to the right ventricle. From the right ventricle, it will be pumped upwards through the pulmonary valve to the pulmonary trunk. The blood in the pulmonary trunk is then shunted from the pulmonary trunk to the descending aorta. That shunt is a third fetal shunt we are mentioning. We call it the ductus arteriosus, the duct of the arteries. So ductus arteriosus carry deoxygenated blood or poorly oxygenated stream of blood from the pulmonary trunk to the descending aorta. And so finally, the blood is in the descending aorta. So you realize that ductus arteriosus has also bypassed the pulmonary circulation, because now blood in the pulmonary trunk has not gone to the pulmonary arteries to the lungs. It has gone direct to the aorta. As I told you from the beginning, that there are two shunts that bypass the pulmonary circulation: Foramen ovale and ductus arteriosus. Now, I want you to note that the ductus serratus joins the aorta after the aorta has delivered its oxygen to the brain. So the ductus serratus is after the left subclavian artery and not before. Because if it was to join before, then our desire of ensuring that the brain receives oxygen may not be achieved. The ductus serratus joins the aorta after the aorta has delivered good levels of oxygen to the brain. That's when it joins. And so definitely the stream we now have here is moderately oxygenated stream. The descending aorta largely contain a moderately oxygenated stream of blood. Good, so let's follow that again from the placenta. Well-oxygenated stream of blood is coming that way through the umbilical vein, then to the liver, ductus venosus of the liver, then inferior vena cava, then right atrium, through foramen ovale to the left atrium, left ventricle, then being pumped to the aorta, ascending aorta, arc of the aorta, then descending aorta. While it is passing through here, we see that the liver will receive the oxygen, good. When it goes through here, ascending aorta, the heart will receive the oxygen. And when it's going through here, the brain as well as the thyroid gland will receive the oxygen before finally it becomes diluted. How about the stream from the superior vena cava coming from the brain, poorly oxygenated for that matter, enters there, then to the right ventricle. From the right ventricle, it is pumped through the pulmonary trunk and then to the ductus arteriosus, then join the descending aorta. Great. From the descending aorta, blood will go down. The aorta usually divides into two. Well, we have the descending thoracic aorta and the descending abdominal aorta. The descending abdominal aorta is simply called the abdominal aorta. Abdominal aorta down there divides into two, right and left common iliac arteries. The common iliac arteries divide into two, each of them, external iliac and internal iliac. The external iliac artery is the artery that goes to the lower limb, so it becomes the common femoral artery, superficial femoral artery, popliteal. It goes to supply the lower limb. The internal iliac artery supply the pelvic internal organs, things like uterus, prostate, urinary bladder, rectum. However, the internal iliac artery also gives you the vessels which go to urinary bladder, yes, and the one that also go to the placenta. And that is the one we call the umbilical artery. So because there are two, we have right and left umbilical artery taking blood to the placenta. You may want to take note, therefore, that the blood going to the placenta is not really poorly oxygenated stream, but more of moderately oxygenated stream. That's the one that goes to the placenta for oxygenation. Right, so that is fetal circulation. We started from the placenta. We've now finished with the placenta. Right, so let's now talk about the circulatory changes which occur at birth. And this, maybe we are actually aware of them. Some of them are really obvious, like that first one. We know that when a baby is born, the blood exchange between the placenta and the baby ceases. Another change. We know that when a baby is born, blood begins to go to the lungs for gas exchange. So we initiate a functional pulmonary circulation. These ones occur at birth. Very radical changes. Now, when blood goes to the lungs, there are some implications. The implication is this. When blood goes to the lung of the baby, now the neonate, it means that a lot of blood will now be coming from the lungs to the left atrium. That has implications. The implication here is that now the pressure within the left atrium become high. And because the pulmonary circulations has now opened up, the right chamber pressure has reduced because now there's less resistance. So the right chamber pressures go down because of opening of pulmonary circulation. But the left chamber pressures go up because now there's a lot of venous return from the lungs to the left chambers. So there is a change in the chamber pressures. Before birth, the right chamber pressures are higher than the left chamber pressures. But after birth, the left chamber pressures are higher than the right chamber pressures. Those differences in chamber pressures have an effect on the closure of the foramen ovale. So closure of the foramen ovale is also one of the outcomes, or rather one of the changes which occur. But let's say that in a better way. How does foramen ovale close? Look at this image. Consider this to be the right atrium and this to be the left atrium. The interatrial septum is formed by two membranes. There's a thin membrane that usually formed earlier. We call it the primary septum or septum primum. And then there's a thicker septum that usually form later. We call it secondary septum or septum secundum. This is how they're oriented, in such a way that the secondary septum is thicker from the roof and to the right. The primary septum is thinner and to the left, which will appear like to be coming from below here predominantly, as what we can see here. Well, in its formation, it was coming from above like that. Then there's a hole that appears up here later, which we call secondary ostium. Now, what I want to pick is that in its final orientation, the thin septum appears to be from below and to the left. The thicker septum is from above and to the right. This arrangement leaves a gap between the two. And that gap is what we call the foramen ovale. Now, before birth, the pressure in the right atrium is higher than the pressure in the left atrium. And so for that reason, blood flows through the foramen ovale in that manner. Because these are thinner septum, it will just flap away and allow a right to left shunting of blood. So blood moves from the right atrium to the left atrium. That's a right to left shunting of blood. After birth, the pressure in the left atrium is high. So what happened? If the pressure in the left atrium becomes high, this thin septum will flap backwards in this case. And so that's what you're going to see. It's going to be pushed back. So what do we see? The foramen is no longer open, but closed. That closure is what we call the physiological closure of the foramen ovale. It involves the flapping backwards of the primary septum. And this occurs at birth. It is caused by pressure difference. The left atrial pressure is higher than the right atrial pressure, and so foramen ovale closes. As the baby grows, the primary septum and the secondary septum will then fuse together in that manner permanently. And that is what we call the anatomical closure of the foramen ovale. The anatomical closure of the foramen ovale occurs within the first 12 months after birth. You need to understand then that when physiological closure takes place, it is still possible for the two septum to separate in circumstances where the right atrium may have higher pressures than the left atrium. For example, if there's a congenital heart disease that makes the right atrium have high pressures compared to the left atrium, physiological closure cannot take place, and so the foramen ovale will remain patent. And that's what we call patent foramen ovale. If a baby cries so hard, maybe the baby is just fallen down, and so they cry, a neonate for that matter. They may cry so much until the right chamber pressures become so high compared to the left chamber pressures. And so the foramen ovale can actually open during that brief moment. It's not something to scare you much because it's just a very brief moment anyway. But during that time, the foramen ovale can close and you can have a right to left shunting of blood during that time. The baby can actually turn blue at that moment when they are crying. But after anatomic closure, we don't expect those reversal of shunts because the primary and the secondary septum has permanently fused. Now, put your eye here and look at this side. When your eye is here, what do you see? You see a depression and you see the inferior edge of the primary septum. That depression, we saw it in the right atrium. We call it fossa ovalis of the right atrium. And that inferior edge of the secondary septum, maybe we see it here better. This is the fossa ovalis, and that inferior edge of the secondary septum is called the limbus of the right atrium. Limbus is L-I-M-B-U-S, limbus of the right atrium. In this image, you can see the valve I was telling you about. This is the valve of the inferior vena cava, redirecting blood to the foramen ovale, now has become fossa ovalis. That's the valve of the coronary sinus, and this is the tricuspid valve. So blood from superior vena cava go here, blood from inferior vena cava go there. Concept of streamline flow. Okay, that is closure of the foramen ovale. Two-step, as I've told you. The other change is that the ductus arteriosus will also close at birth. Now, the ductus arteriosus also has two-step closure. There's the physiological closure, which occurs within a few days, maybe 3 to 7 days. And it involves vasoconstriction of the ductus arteriosus. So ductus arteriosus vasoconstricts. The anatomic closure occurs usually variably within a few weeks, maybe 4 weeks, 5 weeks, 7 weeks, up to 3 months. And it involves fusion of the wall of the ductus arteriosus. So that becomes permanent closure. When ductus arteriosus closes, it will become the ligamentum arteriosus. So there's usually a ligament between the aorta and the pulmonary trunk. That's what we call the ligamentum arteriosus. If that does not close, then we call it patent ductus arteriosus, PDA. Another change is that the umbilical arteries will also close. This is because basically you tie the umbilical cord at birth. So the umbilical artery is closed. When the umbilical artery is closed, they become what we call the medial umbilical ligaments. Medial umbilical ligaments are here. They extend from the pelvis on either side of the urinary bladder, and they go towards the umbilicus, as we can see there. Now, don't confuse the medial umbilical ligaments with this one here, the median umbilical fold. The median umbilical fold is a remnant of the urachus. Remember, urachus is extending from urinary bladder to the umbilicus, a remnant of the allantois. But the medial umbilical ligaments or folds are remnants of the umbilical arteries. Umbilical veins will also collapse and so close. And if the umbilical veins close, even the ductus venosus will close. What does the umbilical vein become? It becomes the ligamentum teres of the liver. So this is the ligamentum teres of the liver. You and I have ligamentum teres of the liver. It connects umbilicus to the liver. And within the liver, there's another ligament, which is a remnant of the ductus venosus. We call it the ligamentum venosus of the liver. Right. So those are the circulatory changes which occur at birth. And we've also talked about the structures these embryonic structures will become. So we'll stop there for fetal circulation and circulatory changes at birth.